Hey, Mehdi.
Carlos Mena is out. Ramon is here.
Hi, Mehdi.
Hi, guys.
Hi. Hey, Mehdi. How are you?
Well, I had a little bit of a technical difficulty, but I figured it out, as usual.
Mehdi.
Gave a heart attack to a couple of people.
Mehdi, you owe us. You owe me something.
All right, I'm going to turn off my phone here, Subhash, so we don't get. I see Ramon is there, so let's figure this out. So, Subhash.
I can hear you.
Okay, you can hear me. Ramon, can you hear me? Can you speak, Ramon?
Yeah, I can hear you loud and clear. Can you hear me?
Yes.
Yes,
Carlos,
fantastic.
Good. I don't see his picture. Carlos, are you there?
I am right here.
All right, my
Carlos,
friend.
you have to turn on your video camera.
I'm not so I don't know how to do that.
Okay, go to the bottom of your screen with your mouse. Just hover on the zoom area and the yes, you're on. You have a light behind you. And if you can turn your camera in a way that it is away from the light, correct, and move your chair.
Got it.
Because we can't see you.
Okay, Carlos, now, Subhash, we're going to share the screen here.
Correct. So, you have to share your screen.
Yeah, I'm going to share here, see if you guys can see.
Yes, I can see your screen. Pull up the slides and go full screen. That's it.
Okay. Can you see full screen?
That's not the one I sent you. This is yours. You have to pull the one I sent you.
Well, did you send me two?
No, I didn't. I sent you only one. Okay. It's okay. Pull it from your email.
Yeah, and the email, there are two attachments to it. So I don't know which attachment was which. This is yours. There's two attachments. My slide, my email.
Yeah, that is one from me, that is yours, and one from me. So just check which other one is. Doesn't matter if you don't have it.
No, we have it. We have it right here.
That's one. That's mine. The top one.
Right.
Town hall.
Yep.
That's the one. That is mine.
We still have 4 minutes, so we can even make some changes if you want.
No, don't changes.
I'm just kidding. I'm just kidding.
Hear me? I'm Mehdi. It's Subhash.
Okay, let me see. Yes, this is good.
Hi, Eric. How are you?
Okay, good. I'm going to just put myself back on mute.
Okay, got
it. Okay. I saved it.
Okay. Perfect.
Okay, that's good.
Perfect. Perfect.
We have 16 participants.
Eric, you also have a very bright light on the ceiling, and it makes it harder to see you. If you can move away from it by any chance, that would be good. If not, then just leave it. I think Ramon's office looks very nice. Very nice background. Looked like he's
saying so.
Subhash, let me ask you a question, Subhash. In regards to the people raising their hand, they can just go to where it says more under participants area, and then it said
you go. No, they have to go. They can go to chat and text, but for you have to go to participants.
Yes. No, I am in participants, but I'm saying that if they want to raise their hand to ask a question.
Yes, they have to go to the more button.
Yes.
Or to go under chat. You see that?
Yes.
But they can't raise their hand like this. They have to go under participants and raise their hand. Everybody has a participant button.
Yes, we see it. Yes, yes.
Okay. So you have to just tell them that everybody has to go to the participant button and raise their hand, or they can go to chat, and that you will mute everybody centrally and unmute someone.
Yes.
Perfect.
Better, Subhash?
That's perfect.
Okay, great. Okay.
That's great.
I'm back on mute.
That's great. Okay. And we are waiting for Carlos. I think this is all good.
Oh, I'm here.
Carlos, we can't see you, buddy.
Right here.
That's great.
I'm just eating dinner.
It's too early.
No, when you haven't eaten all day.
That's true. Ramon, what time is it at your end in Adelaide?
I'm in Sydney, actually, but it's 9 a.m. over here.
Okay, 9 a.m. Perfect.
So
Mehdi,
perfect timing for me.
Your camera down a bit.
Mine?
No, Mehdi's. That's better.
Mehdi, you look so professorial, man, with that little coat of you.
Let me get some perfume here.
What's up with that?
How you doing, buddy?
Okay, we have to start, Mehdi, in about a minute.
Yes. What time is it exactly here? Is 1 minute. Okay.
I'm going to mute myself, or you can mute us and then unmute whatever you want.
I'm saying mute all, but it's not muting. I don't know.
Don't worry about it.
We have about 21 attendees. Okay, I will start at 7:01. Just give 1 minute because there is more attendees coming in. I just want to give a chance to everybody. You guys can hear me?
Hey,
I
Mehdi,
can hear you,
Vic
Mehdi.
Kashyap.
Hi, Vic.
Mehdi?
Yes.
I just joined you. I'm just joining you audio only, though.
Oh, okay. We have everybody else on video. It would have been nice if we could get you on video, but that's okay.
I'm sorry, I'm traveling and the Zoom is not working. I apologize.
No problem. No problem. Okay, well, it's 7:01. I think I'm going to get this started. Good evening, everyone. I know there are some folks calling in and joining the webinar, maybe in other countries or other areas. I know for sure some of our panelists are not from the United States, so good morning, good evening, wherever you are. I really appreciate the fact that the panelists are here and all of you to discuss these important findings and events that has occurred in our field in the last few months. So this town hall is really to discuss the association between drug-coated balloon and drug-coated stents and mortality and the safety concerns. And we are very fortunate here tonight in regards to the panel. My co-host is Dr. Banerjee, and the panel is really a distinguished group of folks that have had contribution already in a short time in this field. As I mentioned, Subhash is a co-moderator with me. We have Dr. Kashyap, who is a vascular surgeon, chief of vascular surgery from UH. He's joining us as a panelist, and he's going to be discussing some of the data from our own institution. We have Dr. Carlos Mena, who's the director of the cath labs at the Yale. And Carlos has also done his own meta-analysis looking at this association, so we're hoping to learn from him. Eric Secemsky, as you know, has already published 2 papers in this short time, and maybe others that I don't know of, both published in JACC and JAMA Cardiology. So I think his expertise looking at other data outside of the clinical trials, which have been analyzed by Dr. Castanos and by FDA, I think are going to be very interesting. And again, we have Ramon Raghu, chief of vascular surgery. He is also, as you know, has done some analyses, and I know he has the editorial in press and others looking at alternative pathways that could potentially explain this association. So given that we have a very short time, let me move on. The goal tonight is that we have a short kind of a discussion, not too many slides, about the various findings as I discussed, and then we have it opened up to Q&A. For the folks, the participants, please, if you have a question, you can raise your hand. Right now, you're in a mute situation, but if you raise your hand, we can ask you to ask your question. And if you want to chat and ask a question via chat, please do so. And we have folks monitoring, and hopefully we can get to everyone's questions and move from there and make it an interactive session tonight in this next hour. So with that, just want to thank again, CVI for supporting this program. As you know, this is a yearly international program that we have put together, covering both coronary, structural, and endovascular. And all of the panelists that are here tonight our participants at this year's CVI in 2019, July, as I've shown here. And I believe Dr. Mena is going to be doing some live cases for us. So it's going to be very interesting, and I hope to see you all there, and we can continue the discussion from tonight. Regarding these webinars, we are hoping to have one of these webinars every month in different areas. Last month, Dr. Sraja did a webinar like this related to tricuspid valve regurgitation and some of the novel therapies that are up and coming. This month, we decided to do it on this topic, which is very important and dear to most of us in the field of endovascular. And we look forward to the future webinars. I suggest that you keep an eye on these webinars because I think you will find it interesting and hot topics. So with that, let me invite Subhash Banerjee to kind of give us an idea as to how did we get here? Why are we even discussing these safety issues? We were so excited by all the efficacy. Subhash?
Thank you, Mehdi. I hope you can hear me. Very, very briefly, as Mehdi said, we want to keep this session very interactive. This field has made a great impact. I mean, the technology of DCBs and DES in improving outcomes of patients who are undergoing clinically symptomatic therapies, endovascular therapies in the femoral popliteal area. And the field, as Mehdi asked the question, how did we get here? I'll get to the point that there was a meta-analysis, as you are all aware, published by Dr. Katsanos in JAHA in 2018 end in December. And that included a meta-analysis of 28 RCTs, compiling over 4,660 patients, 12 different devices, both stents and balloons, and also including combination therapies, predominantly in claudicants. About 89% of patients were claudicants. And I show on the slide, in very quick succession, 1 year, 2 to 3 years, and 5 years analysis, a meta-analysis. And the first figure on the screen is the 1 year reported pooled estimate. As you can see, this is from 4,432 patients. The pooled risk of death did not differ significantly between the paclitaxel coated balloons or stents versus the control arm. It was just about the crude risk of death was 2.3%. And there was no statistically significant heterogeneity. The 2 year and 3 year, most of this data actually, I want to correct that, is actually 2 years, included 12 studies and about 2,316 patients. The 101 deaths were recorded in 1,397 participants, 7.2% crude risk of death in the paclitaxel arm, 3.8% in the control PTA arm, and the absolute risk difference was 3.1%. As you can see, the risk ratio is statistically significant, both using the fixed and the random effects model. And the 5 year is where, which was probably the more exciting part of this information, where the crude risk of death was 7.2%. In the absolute risk of the absolute risk difference was 7.2%. It was 14.7% in the paclitaxel and 8.1% crude risk of death. And again, the risk ratio was statistically significant, and there was by both the fixed and the random effects model. So I'll stop there and hand it over to Mehdi. I hope he will invite all of you, all the panelists, to join in, and all of you to chime in with question. I just want to add one thing. If you hover on your screens and go to the participant, you will be able to raise your hand and even dial in your questions through a chat message. So Mehdi, all to you.
Thanks, Subhash. So we're going to kind of say a brief indicated earlier. So with this, I'd like to move on to Eric Secemsky. Eric really has done a fantastic job, in my opinion, because in such a short time, he's been able to publish 2 important high top-tier papers in the field. And Eric, can you highlight to us, I think the importance of your work especially is that you use data outside of what Dr. Castanos and FDA has used. Can you give us a brief idea as to what data you used and what your findings were in these 2 papers?
Great. Thank you, Mehdi. Appreciate being invited to speak today. So we performed 2 analyses pretty quickly, as Mehdi had kind of mentioned right after we saw this meta-analysis, the goal, the main concern we had about the meta-analysis was the inconsistent follow-up for patients, especially as they reached 5 years. So as you can see in those individual studies that are presented in the meta-analysis, the authors presented the data that is available, which is not 100% for all the trial enrollment. And so we're really trying to figure out how we can overcome that issue while also getting some duration of follow-up to show whether there is or not a safety signal. The first analysis that we did is the one on the right, which is published in JAMA Cardiology in the beginning of February. And what we used is Medicare beneficiary data for inpatient femoral popliteal artery revascularization. And we used the ICD-10 PCS coding system, which allows us to identify either a drug-coated balloon, drug-eluting stent, or a combination of both, as well as a bare metal stent and a PTA, uncoated PTA, used for femoral popliteal artery revascularization. The population for that study was 16,000 patients. We had a median of 389 days of follow-up, but we had 1,000 patients that went all the way to 600 days of follow-up. And what we found was in a crude comparison between patients who were treated with any drug-coated device versus a non-drug-coated device, we found no difference in survival out through 600 days of follow-up. We looked at that in both patients who had critical limb ischemia and those without critical limb ischemia, as well as those treated with a drug-eluting stent versus a bare metal stent, and a drug-coated balloon versus a non-drug-coated balloon. And we found no difference in survival. We additionally adjusted for patient, procedural, and hospital characteristics using Cox regression models to make sure that there was no differences in patient populations accounting for the lack of survival difference. And again, we found no difference in the risk of survival in comparing those treated with drug-coated devices and those without drug-coated devices. We were really confident with these results and felt that these help address some of the questions, primarily between year 1 and 2, where we saw that 3.5% risk difference. We couldn't find that signal out to 600 days. So we'd be surprised if between 600 days and 2 years, that all of a sudden there was a 3.5% difference in mortality. So overall, we thought in a very representative real-world population with near complete survival data that we couldn't reproduce that signal. One issue with this analysis is that we couldn't reproduce the survival follow-up out to the 4 and 5 year mark, which was some of the more impressive data from Katsanos. And so what we did is, because ICD-10 codes were used in Medicare starting in October 2015, we just didn't have that data available. We moved to the ICD-9 coding system. And so ICD-9 has specific codes for peripheral drug-eluting stent versus peripheral bare metal stents, so non-coronary drug-eluting bare metal stents. And we timed our analysis right around November 2012, December 2012, when the Silver Ptx was released in the US. Now, there's no ICD-9 code for drug-coated balloon, so our second paper only looked at patients undergoing inpatient revascularization with a drug-eluting or bare metal stent in the periphery. But we had a large population, over 50,000 patients, and we showed over a median of 2 years and out to 4.1 years, there was no difference in survival between patients treated with a drug-eluting stent versus a bare metal stent. We again stratified that analysis by those with critical limb ischemia and non-critical limb ischemia, and those survival curves were overlapped. We adjusted for patient and procedural characteristics, and we again found no adjusted risk for decreased survival or mortality risk with drug-coated devices. So in conclusion, we have 2 large Medicare beneficiary patient populations with follow-up varying between 600 days out to 4 years, with over 65,000 patients in total. And in the group, we found no difference in survival any which way we looked at the data.
Eric, that was fantastic, really impressive, large databases, looking at 2 different ICD codes, and also obviously both in claudicants and CLI. We know that we don't have randomized data in CLI. So we have a lot of questions we want to ask you, but let me move on, as we gather the information before we get to the Q&A. So let me, with your permission, let me move on to Ramon Raghu, and I know he's done a lot of work. I have had the pleasure of working with him on some stuff. Ramon, I know you've been very passionate about this area and about potential alternative explanations for this association that we have seen from Castano's paper. Can you kind of walk us through your thought process and some of the work that you are doing? Thank you.
Yeah, absolutely, Mehdi. Thanks for the opportunity to speak here today. So I don't have any slides, but I'm just going to speak for a couple of minutes and happy to answer questions at the end, of course. So I think, like most of us, when I first read the Katsanos paper, I was pretty impressed by the powerful risk association and the degree of safety signal observed, particularly at the 4 to 5 year mark. However, as we started to dive deeper into this association, it became apparent that despite the strengths of the statistics, the likelihood that paclitaxel was actually killing people was extremely low. To start with, the medical community had been using paclitaxel for more than 25 years in curative cancer patients and had observed no increased mortality. Those patients were getting paclitaxel in doses between 200 and 400 times that of a drug-coated balloon, and they actually lived longer than patients who didn't receive paclitaxel. The VLFN Washington, DC was interesting in that none of the toxicologists or scientific researchers could find a plausible biological mechanism for paclitaxel-related death. The oncologists, in fact, that presented there, they felt that paclitaxel was so safe, they were happy to give it to pregnant women, which is pretty unusual for a drug like this. And when we went back over the patient-level data, it became apparent that there wasn't one dominant cause of death. So without a plausible mechanism of toxicity or a smoking gun cause of death, we started looking for alternative explanations for the association. So the first theory I wanted to raise was around clinical trial design. We all know that RCTs are designed to compare drugs to one another or to placebo. And it's also well established how important it is that these trials blind participants, the healthcare team, and also the outcome assessors. However, in contrast to pharma trials, in device trials, it's very hard to blind the healthcare team to the subject's treatment arm, and they're mostly aware of what type of device was used. And it's that very same healthcare team who generally determine whether a patient has died. Of the 28 studies that were included in the Katsanos meta-analysis, 100% of the healthcare teams were unblinded to treatment allocation. And those authors consider that that had introduced a high risk of bias to their own meta-analysis. So the bias we're talking about here is called ascertainment bias. It happens when the people who are charged with the responsibility of determining whether a patient who's been recorded as lost to follow-up is simply no longer contactable or has actually perished. That bias may be conscious or unconscious, and it's known to influence the tenacity with which healthcare workers pursue the patient outcome through contact with a local doctor, family, hospital medical records, or Medicare documentation. Remember, mortality is a low-frequency endpoint, and it can easily be influenced by just a small number of subjects being misclassified. And we're not talking about a small number of patients being lost to follow-up either. In the Silver Ptx trial, that number was approximately 30%. It was in the high teens in the Impact SFA trial, and in Thunder, it was as high as 46% in the PTA group at 5 years. That represents almost half the patients lost to follow-up in one of the 3 trials that made up the 5-year meta-analysis, which I think is pretty astonishing. So let's call it, this seems to be a failure of clinical trial design. But remember, these trials weren't designed to evaluate mortality. Mortality was a secondary endpoint, an afterthought if you like, which has historically been given very little consideration during the trial planning phase. If we really want to evaluate mortality, we have to design trials for that purpose and make sure that we collect the data without those same proportions lost to follow-up. It is my view that the unblinding of the mortality adjudicators and the significant proportion of subjects lost to follow-up raises significant concerns around the accuracy of the pooled estimate in the Katsanos study. In fact, I would go further and say it casts doubt over the entire legitimacy of the meta-analysis itself. The second theory I wanted to discuss was the difference in medication compliance and medical therapy regimens in each of the study arms. So drug-coated devices are known to reduce TLR rates. That's not under any debate. With increased rates of TLR, in the patients who received uncoated devices comes more presentations to the healthcare team. And each of those presentations is an opportunity to make sure the patient is compliant with their medical therapy and that risk factors like dyslipidemia, hypertension, hyperglycemia, and smoking cessation are all being attended to. What's more, patients who have more frequent TLRs are likely to have their medical therapy escalated. It's common to add an additional antiplatelet agent or even anticoagulation in patients who are experiencing patency failure. Each of those things is known to reduce mortality. So this has been borne out in the Impact DCB clinical trial program, which was presented by Peter Schneider at Link and then published subsequently in JACC. That study looked at around 2,000 patients who received treatment with the Impact Admiral DCB or PTA. They were all rigorously adjudicated and independently analysed at patient level by BAME. And there were two very significant findings from that. The first was that patients who received PTA were more likely to be compliant with follow-up than those that received DCB. Those numbers were 94 versus 88%, and that was highly statistically significant. The second finding was that those patients who died were less likely to have been compliant with follow-up than those who survived. Those numbers were 83 versus 88%, and again, that was highly significant. So that's an example of patient-level data supporting the theory that patients who are more compliant with follow-up and who return to the healthcare team because of increased rates of TLR are likely to have a survival benefit related to risk factor control and compliance with or escalation of medical therapy. So these are two plausible mechanisms for the observed statistical association between paclitaxel-coated devices and the higher rates of mortality. In the absence of a rational, biologically plausible mechanism for paclitaxel-related toxicity, I think these two alternative theories become all the more compelling.
Ramon, that was really fantastic. And we have some other questions. I'm sure many folks have questions regarding intention to treat and some of the other potential alternative explanations and how we should look at this association. I guess the bottom line is that what we're trying to figure out, all of us, is this a statistical association or is this a mechanistic, biologic, clinical association? So I appreciate you giving us the insight in regards to the ascertainment bias and the follow-up and the intensity of the care. And we're going to come back to you with some other questions related to this. So with that, let me move on here to the next presentation. I was going to ask Dr. Mena, Carlos here. I know he has done his own meta-analysis, and I know he has extensively evaluated Castana's meta-analysis. Carlos, can you tell us about your paper? I don't know, I think it's still in press, but give us some of your insights into this association.
Yeah, Mehdi, for sure. So a couple of things. The paper was published already in the Journal of the Sky Society last month. And I think there are a few points that I'd like to make. Certainly, from the statistical point of view, as it was just explained, there are a lot of different issues, and we have to become more educated about how to interpret that data. But there are a few other things to take into consideration. One of them is that meta-analyses are not necessarily designed to answer questions, but rather to be provocative and generate data. Certainly to generate hypotheses that hopefully, ideally, should be followed up by studies well-designed that are designed with a specific aim. As he was saying just before, you know, if you want to assess the issue of mortality, then the study has to be designed to prove that. And most of the trials that have been done in this space are not necessarily done with that intention. It becomes a serious limitation. But the other aspect of it is that whether good or bad, the Cansanos paper has brought to life a lot of different issues that exist within this space, with the peripheral vascular space. And if you allow me, before I go into my paper, I would like to make a few points. I think that many of the trials and the studies that are driven by industry have significant issues and bias and question the credibility of those when we come into a situation like the one that Medtronic, for instance, that suddenly some of the patients became known that were lost to follow-up. I think that had this issue of the Cansanos paper, whether it changed or not the outcome of the paper, but if the Cansanos paper had not come to light, those patients would have not been taken into consideration. Then you have the issue of Cook, in which their publications were different to what they intended to, and it made it all the way to circulation. So it calls into question that we as physicians have to be more careful and really, really look at what we're being fed before we make our decisions and bring it to our patients. Certainly the pool patient analysis is important, but I think that it should be done independent from industry. And certainly the people that do it should put it out there what their conflict of interests are. In addition to that, many of the trials are run entirely by companies, by industry. Issues like the ones that was highlighted just a few minutes ago in terms of loss to follow-up, swapping groups, no reporting critical events, unless, for whatever reason they are pressed on, it becomes a real problem. Societies have to take a strong stand in all these situations, because we joined these different societies with a purpose. And you at Sky have done a great job trying to come up with a clear position about this. But others, like the American Heart Association and American College of Cardiology, just to name a few, have not been that strong about it. And I think it's important, whether they are against it or for it, to decide where they're going to stand. And lastly, but not least, the responsibility of the authors of each one of those manuscripts has to be, really taken seriously. And they have to make sure that when the papers are not written by their company editors or what have you, because at the end of the day, it's their name, their reputation, and their science. And I think this mess with consensus highlights a lot of those issues. And it's important to recognize them, because if not, we're going to make the same mistakes. What we ended up doing with my group at Yale was basically trying to reproduce his meta-analysis, but this time just focus on drug-coated balloons specifically. And we did something simple like we used to do back in med school, and we look at all the different databases, basically 5 of them, PubMed, Embase, Cochrane, among others, and we look for all the randomized controlled clinical trials looking at drug-coated balloons between 2000 and 2018. Basically, we limit our search strategy to SFA disease because that was our intention, and obviously drug-coated balloons. We end up identifying a number of studies, a total of 22 randomized controlled clinical trials. They yield about 3,000 patients. Most all of them were basically in adult people, and basically they were comparing drug-coated balloons versus plain balloon angioplasty. And just to the point that is being addressed tonight, we were looking at TLRs, patency, and all these other things, but the specific point of mortality, we look at it in so many different ways. And I didn't want to do any fancy analysis or anything beyond what Cansanas had done. And we did not find any statistical association between drug-coated balloons and mortality. So what is it then? And I think that a lot of it is what had been described before, and is the issue of a certain bias and the way the meta-analysis was done and the statistical analysis of it, which led to perhaps this conclusion. But when you run it on an unbiased base, there doesn't seem to be such. I don't have a slides to show my paper right now, but you guys can go to the Sky Journal on the issue of March, and the paper is published there. So with that, I finished, Mehdi, and I'll give it back to you.
No, I think that was very nice, Carlos. I think you really brought in another angle to it. And that is that, definitely, I think as a field, we need to be much more rigorous. We need to be much more careful. Some of the things you highlighted with some of the data that was later corrected, some of which were corrected 5-7 years later, that we learned that, we had the wrong data for 7 years. So I think you have highlighted some very interesting points that honestly, not too many people are talking about. We are focusing so much on the DCB and this association that we have lost maybe track of some of the angles that you brought in to the conversation that is going to require much more attention in the future. But I appreciate the fact that you did the meta-analysis on DCB, and I wanted to get your perspective. It's interesting that how you can do these meta-analyses but come up with a different result. And I know there are others that have also looked at this and have found no association. So there is some trick to it, and we get into it. I think Subhash is going to also give us some perspective. So with that, let me go to my partner, Vic Kashyap, who has decided, what, I don't believe anybody. I'm going to look at my own data. So we have looked at our own patients, and he has led this with over 1,000 patients and looked at to see if there's an association between drug-coated balloons and drug-eluting stents and mortality versus other devices. Vic, can you give us a brief description as to what you found and anything else you want to share with us? Thank you.
Well, thank you so much, Mehdi. Thank you for including me in this phenomenal panel. We were very concerned based on the meta-analysis that's already been described. And I think we were even more alarmed when both Medtronic and Cook revised their mortality data many years after publication of the papers, as already alluded to. Because of that, we looked at our own experience, wanting to make sure that we were not missing something. And between 2011 and 2018, we had approximately 1,200 patients that underwent femoropopliteal percutaneous revascularization. Interestingly, we had a fairly equal group of patients that originally had undergone plain balloon angioplasty with or without atherectomy and stent placement, and then starting in approximately 2015, patients that had undergone angioplasty with a drug-coated device. Most of these were paclitaxel-coated balloons of either the Lutonix variety or the Medtronic variety. After carefully looking at this data set, we had 890 patients that had fairly rigorous follow-up, had assessment in the vascular clinic, had some type of ultrasound or other vascular lab non-invasive study to assess patency. I will say there's a limitation with this data set. As I told you already, there are a couple hundred patients that have been lost to follow-up. We're trying to capture those patients either by telephone or office visit rapidly. We have 4 people working on probably on the phone as we speak now, trying to get those patients back for a complete understanding of this cohort. We also have an unequal group in that the patients that had some type of paclitaxel-coated balloon are later in this 7-year experience, so the length of follow-up is not equal. Despite those limitations, we found globally no difference in all-cause mortality at 1 and 2 years, and at 3 years, actually a slightly decreased risk of death in the group getting paclitaxel-coated balloons. It is just barely statistically significant, and it may be altered when we get the final data set, but that was intriguing and in contradistinction to what we've heard recently. We then propensity matched patients to equalize risk factors, and again, there was no difference in mortality in patients that had paclitaxel versus non-paclitaxel-coated balloons. Excuse me. Next, we looked at paclitaxel dosing in these patients that received those balloons, and we used a surrogate as the total balloon length, meaning less than 10 centimeters, 10 to 20 centimeters, and greater than 30 centimeters of coverage in the femoropopliteal location as a surrogate for the amount of paclitaxel dose that was given to the patient. And again, there was no difference in these Kaplan-Meier curves, regardless of the dose received to the patient. I will tell you also that this is a little bit of a mixed bag of patients, including half that are claudicants, half that are critical limb ischemia. Just yesterday, we separated out those groups, and we have about a 90% survival at 3 years in the claudication group, and about a 68% survival in the critical limb ischemia group at 3 years. And paclitaxel versus non-paclitaxel exposure did not affect survival. So cautiously, we can say, at least to our patients here in Cleveland, that currently in our experience, we are not seeing the same signal that is a difference in survival, whether one does or does not receive this balloon, with the caveat that the patients that were exposed to paclitaxel are later in our experience and need continued rigorous follow-up that Mehdi and I and others in our group are going to continue to do. Thank you.
That was fantastic, Vic. Very nice, kind of presented, and I appreciate all the effort that you guys have put to this because it's now we are seeing data from Eric, looking at the ICD codes and the large databases. We are seeing the repetition of the meta-analyses from Carlos Mena. We are seeing the work you're doing locally. And then we have obviously the work that Ramon is doing in trying to explain that, okay, if this is not biologic, if this is not a causal association, what else can it be? I know Subhash has some thought-provoking slides that he put together. Subhash, let me take you, because these are very interesting viewpoints and slides. So tell us, and then we get into the Q&A.
Mehdi, I'm going to, we are running a little short on time, so I'll use my time to ask Eric and Ramon a few questions and get the juices flowing, because these guys, our panelists, look way comfortable, and we are not challenging this and not, you know, Eric is even smiling. How could he be smiling on a webcast? We're going to give him some heat here. So Eric, you know, you are very familiar, and I put up this slide just to provoke you. This is courtesy the Link meeting, and this was a beautiful presentation that that was presented at Link, and this slide is courtesy the meeting and the session that was held specifically on this topic. But we do want to dive into the methodologies of meta-analysis. So please tell me first, what was the reason behind your splitting the data into claudicants and CLI, number one, in your paper? And second, did you do a dose relationship like the meta-regression that was done in the Katsanos paper? And because you have such a good stronghold on biostatistics, do tell us in general, are these meta-analyses by definition able to grasp the question around causation? And is meta-regression a valid tool in this environment to put forth these facts? So take it away, please.
Great. Yeah. So to address those questions, so the the comment about device. Well, first I'll talk about the CLI versus claudicant. So I think that was really a critical part of both of our analyses. So our analyses are strengthened by numbers and follow-up, and that's really where we come at it with a broad real-world population with a large patient population. And we have very specific codes for devices used, and we have specific codes to identify patients who have critical limb ischemia and claudication. Now, the reason to stratify those populations, and we all know this as practicing vascular clinicians, is those are two very different conditions. Again, a CLI patient, particularly one that's at risk of limb loss, has a mortality rate that's substantially different than a claudicant. And so the things that are on the line are a little bit different, and that's really important to the FDA as well. From the claudicant standpoint, they tend to be treated, they more have single level disease and tend to be treated with a lower dose of paclitaxel. They also have an improved prognosis. And so if we're going to cause harm, we want to make sure that we are following these patients who are likely to live 5 years through 5 years. And if there are alternative treatment options, we need to be really mindful of the fact that we're using the safest treatment for our claudicants. Not that we want to do anything differently in the critical limb patients, but critical limb patients often have multi-level disease. Their prognosis is poor. It's almost like a metastatic cancer diagnosis. And so some of the goal of therapy is to keep them out of the hospital, which we know we're accomplishing with drug-coated balloon. And so the risks are a little bit different, and what's on the line is a little bit different for these populations. So I think it's important to put them together as we start the analysis, but also to really pre-specify, looking at individual patient populations, stratified on that disease standpoint, to understand, again, if we're going to reproduce this signal, how big is it in each population? What's the risk to the patient? What are the alternative treatments? And so forth. Now, from the dose question, so in Medicare data, you could identify the device used. You can't identify which specific brand of device. So I know a drug-coated balloon was used. I can't tell if it's an Impact or Lutonix, and I can't tell how many treatments or if there's multiple treatments. So that's bundled in the procedure package. So the limitation, again, when you get to these large claims-based registry data, is you lose the granularity from the procedural standpoint. And that's where the data that come from people like UH hospitals really stand out when they have the granularity to do that. Meta-regression is a great technique used in meta-analyses to deal with linear questions. So question of if you linearize an exposure, such as the total drug-coated difference, can you find the continuous risk of death as plotted in these graphs? But as we've discussed at BLF, there are a lot of components in the estimates made for the original meta-analysis, particularly time was a consideration, and also the actual length of treatment that was kind of presumed in the meta-analysis that were probably wrong estimates. And so when we've looked at other data like Peter Schneider's impact data from Medtronic, we haven't been able to reproduce the finding that increasing dose of paclitaxel actually corresponds with increasing risk of death. The last comment, Subhash, I think you asked, is about the statistical techniques used for these meta-analyses. The only comment I again will end on here is that when you use summary level data, you lose two components. One is you have only the top line results. So whatever is written either on an abstract, if it's not published, or whatever is reported from the enrollment criteria, such as in Silver. You only look at the enrollment population in this meta-analysis. So you lose the ability to use time to event data, which is really important. So when there is any consideration of loss to follow-up, whether you're censored because you pulled out of the trial, whether you died, whether you had an adverse event, whatever reason you're no longer being followed in that trial, what we do in typical statistical methodology is we censor you. You're no longer contributing data at that point. But when you look at a summary level meta-analysis, you can't do that. You look at it just based on your enrollment criteria, which is what kind of Ramon talked a little bit about for the Silver trial and some of the other trials. And so there are better statistical ways to account for time to event data that was used in this meta-analysis. And I think that's a key that's being addressed with the VIVA's patient level analysis.
Thank you, Eric.
Slide, Subhash. Subhash, what was your point on this slide?
The point was I was trying to provoke Eric to bite on it, but he kind of avoided it. The meta-regression analysis, and I'm not an expert again, shows the relationship of all-cause mortality to paclitaxel dose based upon exposure calculation. And as in the link meeting presented, you could do a very similar analysis by looking at the number of letters in the study title over time. So I think the point here is that meta-analysis, like Ramon said and Carlos said, are very useful. And I think they shouldn't be discounted, but I think they are merely a suggestion of association and trying to derive, in my humble opinion, inferences about causation from this, I think maybe a little bit unfounded and maybe fairly limited. I just want to follow up with Ramon, Mehdi, with your permission, a very quick question. I think I want to pick up with Eric. Eric just said the differences between study level information and data and meta-analysis and patient level meta-analysis. And I think a lot has been said about it. And I would like for you to comment for our viewers and listeners how those two studies and those two types of meta-analysis could be very different, and especially when we are looking at mortality, causes of death, and the numbers are relatively not very large. Could you please comment upon that, and from your own commentary, how do you view patient versus study level meta-analysis?
Well, I think, Subhash, in terms of the hierarchical evidence pyramid, the well-conducted meta-analysis is right up the top, being level 1 data. But when you really drill down onto meta-analysis of summary level versus meta-analysis of independent patient level data, you see that secondary type of meta-analysis rise even higher. And the reason for that is because you gather so much more information when you go back to patient level. If you're looking at an endpoint such as mortality, as Katsanos has done here, the real questions are begging to be asked. What is the time to event structure around these deaths? And what was the cause of death? And because we're still grasping at this question of how paclitaxel may or may not cause death to a patient in the long term, without that more detailed patient level data, we can't do anything more than demonstrate an association, as you've just said in your opening remarks. Could I make another comment, though, on a slightly different topic? It's related to this particular slide. And I must say, when I first read this paper, looking at this figure of the meta-regression and the dose dependency of the paclitaxel, I was pretty convinced. This to me was the icing on the cake and really had me thinking this was all true. But I think it's worth pointing out to the listeners that there is certainly a problem with this particular assumptions made here. So if you look at the dose versus time formula equation at the bottom, the authors have assumed a constant exposure over time to paclitaxel. And I think what we know from people who specialize in the biochemistry of paclitaxel is that it has a very short half-life of around about 6.9 hours, and it is undetectable in the serum within 24 hours. So the assumption that they've made here is just purely incorrect. And the second assumption they've made is that the patients in the uncoated arms of the trials were paclitaxel naive. Now, we know that's also not correct. Many of these patients crossed over to the active drug-coated arm, and the ones that didn't but came back for TLRs, well, I don't know about your practice, but in my practice, patients who come back for TLRs almost always get a paclitaxel-coated device. So the assumption of them being paclitaxel naive is also incorrect. And that's where this whole thing falls in a heap.
Fantastic points. Thanks for making that. Mehdi, over to you.
I'm sorry. I just wanted to make a quick comment about this patient-centered analysis, because I think that people are not necessarily understanding or following that.
Correct.
I'm talking about the people on the panel, but more so the audience. And if I may, I want to use, for instance, the example of the Silver Ptx trial. Complex trial with difficult design, with primary and secondary randomization. But if you follow my lead for a second, it was a trial where Silver was randomized in the first go-around versus PTA, and in the second go-around, Silver versus bare metal stent. In the control arm, in the PTA arm, there was an assumption that if the patient came back with restenosis during the first 5 years, that patient was then be treated with Silver Ptx, which resulted then in that about 40% of the patients that received PTA in the Silver Ptx trial actually end up getting Silver Ptx. That's crazy, because that is not something that is readily available, that the regular reader has access to, let alone understanding of it. And it highlights the importance of doing patient-centered analysis, because here you're making assumptions based upon a summary from a trial paper or whatever. But the reality is that 40% of the patients that you're assuming that got this PTA actually did get Silver Ptx. And I can go into every single one of the trials and highlight similar differences. But it's crazy to think for the regular reader that they are missing 40% of the patients because they actually got the Silver Ptx.
Gentlemen,
so that alone highlights the importance of doing this patient-centered analysis.
I think these points make our juices flowing. So these are extremely important points. Mehdi, you have a question for Kashyap, and then we should open the lines for, unmute the lines for the audience. We are getting close to 6:46. So please take it over, Mehdi.
No, I think these are great points. I think Carlos is mentioning the intention to treat, that I raised earlier. But I think one other point I'd like to make quickly is that a lot of people are waiting for this patient level data to really give us all the answers. And I have really serious concerns about that, because many of these patient level data are going to come from these clinical trials. And unfortunately, some of the important variables that we need to adjust for to understand this association are most likely not captured. So in addition to all the things that Ramon said and Carlos is mentioning, is that if we keep analyzing the same data, and that's one of the challenges I have, because just to make the conversation more practical, is that the FDA now has two announcements, right? They made an earlier announcement, which was a little bit milder, and now they made a second announcement, which kind of put a lot of physicians in a little bit of a corner. So we are sitting here, I feel, as I'm listening to you, that the evidence is not there clinically for us to be that concerned. We're all saying that, yes, we need more data, we want to learn more, we want to capture more information. But I don't hear anybody saying, you know what, at least, and I want to go one by one and get your practical kind of answer in regards to what do you do now? I mean, we've seen data from Eric, we saw data from Dr. Kashyap, we saw data from Carlos Mena. Ramon, you told us your ideas about the alternative pathways. So let's start with Ramon and go to Vic, and then Carlos, and then Eric, and then maybe even Subhash. And let's tell us practically, what are you doing right now when you have patients with all the information that you have generated yourself or that you are aware of based on these discussions? Ramon?
Mehdi, I would just say that you should unmute the line. So if people want to jump in and interrupt, this would be a great time to do it.
If they raise their hand, I will unmute it. Thanks. We have about 80 people online. I don't want 80 people to speak at the same time.
Great point.
So, Mehdi, just to answer your question, my practice hasn't changed very much. I think that the FDA warning letter that came out on the 15th of March, although being a little bit over the top in my view, made it clear that there are patients who benefit from paclitaxel still, and they're the patients prone to restenosis. And that's most of my clinical practice, to be honest. I'd have to say the only patients that I perhaps will think twice about using paclitaxel now will be the young claudicants with very long lesions that require multiple balloons. I might try to avoid using paclitaxel in those in that small group. But for the rest of them, I'm still using paclitaxel avidly, and I'm just taking a bit more time around the consent process now and informing patients about the safety signal, which has been a little bit of a work in progress, but I think I've got a good way to explain it to them now.
Yes. Thanks, Ramon. Vic, can you tell us your practical practice?
Yeah. Can you folks hear me? I'm
Yes.
Traveling. I hope it's coming through okay.
Yeah. Thank you so much for, by the way, joining.
Yeah. Well, I want to echo Ramon's comments. I think he beautifully summarized the kind of the paradox for all of us. We did temporarily, when the alert came out, kind of pause. In staff meetings, we discussed this pretty avidly. That's what led to the retrospective review of our own patients. At this point, though, I think we can safely tell our patients that in our experience, so far we've not seen this worrisome signal. We're going to follow these patients as we have, in past, but we're going to try to be as rigorous as possible to follow them very closely. To make sure that we're not missing something down the road. And obviously, as one of my heroes, Norm Hertzer, said, results are everything. Following your own results, following your own patients really sometimes highlights problems or leads to really a situation where you're not alarmed by things that may be due to statistical flaws.
Fantastic. Carlos?
So Mehdi, 2 points. One, my clinical practice has not been changed by this data. But 2, the consent process has changed. And in my original consent, I wouldn't disclose this risk associated with this drug delivering device, and now I do. And what it has had a major impact is in our clinical research program. As you know, there are a few clinical trials with drug-coated balloons ongoing in the US that have been either temporarily stopped or slowed down, and it has become really challenging to enroll patients in those trials as a consequence of this. But my clinical practice itself has not changed in terms of whether I use or not these devices and how I use them.
I think I'm okay to say this. I am fortunate enough to be involved with the chocolate DCB trial. And I can tell you that the FDA has not asked us to stop the trial. The only reason we slowed the trial down and put it on pause because of the consents. So we had to redo the consent to at least have some information about this so that patients are informed. So it's been interesting. And as you know, at least I know there are a couple other trials. The Spectronetics is doing a below-the-knee trial with DCB, and they are ongoing. I know they're engaging, and they also had to change the consent form for us, to be able to conduct this study. So even the FDA is not asking us per se to pause these trials. And as you know, even the BEST trial, the BEST CLI trial, did not pause. They left it at the discretion of the operators to decide whether they want to use DCB or DES or some other technology. So it kind of been interesting. But thanks for sharing your thoughts. Eric?
Yeah, so I'll say my opinion, again, is that these devices are safe. And as stated by the other panelists, I've changed how I consent my patients. I will say this, though. I'm a minority in my institution who are using drug-coated or willing to use drug-coated devices at this time point, and it's made it an issue for my practice. And I think that's really been the fallout of this FDA letter. And I'm really biding time right now until we get to that advisory panel in mid-June. And, Mehdi, I think you made this point and others, the problem that you brought up, and again, I spoke in favor of the patient-level meta-analysis, but also the problem with the patient-level meta-analysis is there's a good chance that we look at the same data in a different way and get the same answer, and that doesn't mean it's still the right answer. I think there is a concern that that data is fatally flawed. And again, a lot of it is whether there can be complete follow-up or not. And so my approach right now is we're working on alternative data sources to complement what I've already shown in the Medicare registry. And really what you guys are doing at UH and elsewhere, we're trying to show that we can't replicate this in any other reliable large source. And I'm hoping that at the time of the FDA panel and moving forward, that we have a plan of action for following these patients as stated, and show some more, really confirmatory safety data that I can go back to my previous practice, which is largely supported by my partners.
Yeah, Eric, let me ask you a question, related to this. I know your partners have looked into the VQI, I believe, and correct me if I'm wrong. And my understanding is that when they presented the data, they also did not see an association. Is that correct? Can you comment? Are you comfortable commenting on their analysis?
Yeah, the most updated data is probably the similar data that you saw at VLF, which was a little over 1 year, that showed no difference in survival. The problem with the VQI right now is that how those quality registries are designed is you do your own follow-up and submit it. And so again, there's a lot of, as Ramon pointed out, there's some ascertainment bias and also just some lack of data that is not there. And so there's a push to try to do more merging of these registry data with Medicare or other type of large beneficiary data to get more complete follow-up. But the VQI right now is only what I've seen is through a little over 1 year. And again, it's not complete follow-up. So, I think we're all hoping that we'll get more data from that, as well as from the NCDR PVI registry, which we've been working on trying to get data from. And so, there's nothing, the nice thing about the Medicare data is we have really complete data for the longest period of follow-up at this point, but we'll see more data soon, I'm sure.
But so VQI, and I'm not sure about NCDR, but VQI specifically, I have submitted a few proposals in the last 4 weeks about DCB, and they are not releasing the data on drug-coated balloons and drug-eluting stents until this issue has been resolved, which I think is actually crazy. It should be the other way around, because they have the data and they should be able to give us more insight as to not only how they are being used, but what outcomes are they getting in the real world. And now they're not giving the data out because of this controversy. That doesn't help.
Right, that's unusual. Subhash, how about you practically, your practice, how are you dealing with this information?
Completely agree with our panelists. Just the thing is that instead of using my own words, we have simply asked our legal counsel to propose a statement that we include in the consent. And so I leave it there. And I think this has been an astounding discussion. And Mehdi, over to you.
No, I guess my only one, we have about 4 minutes. I want to be a little bit more tense about this and get your view on this, because as you know, the DCB utilization has gone down about 30 to 50% already in just a short time. And I go to these panels, I go to VLF, I see that the preponderance of the folks are saying they don't believe there is an association. I'm sitting on live panel cases. I see the whole panel, 8 people, 9 experts. They say, no, they would use DCB. I come on this kind of a webinar. I see that all of us are saying, I'm the same. My practice has not changed. So what kind of a negative impact is this going to have on our patients if there are so many of my colleagues that I respect, the folks on this webinar, others that are saying, listen, we don't believe this, we don't believe this. Ramon, what do you think? I mean, is this appropriate? I mean, what should we do here, as experts, as physicians?
I think it's a really good point, Mehdi, because people are reacting fearfully after the second FDA letter. And I think what most people perhaps haven't thought through very clearly is that by withholding paclitaxel from your patient, you're also doing them a disservice. We know that creates more TLRs, more returns to the cath lab, and with that comes its own series of risks. So I would say that at the moment, we've got a safety signal for paclitaxel, which is uncertain. We don't know whether it's truly a toxic effect or a statistical association. But what we do know for certain is that if you withhold paclitaxel from your patients, you commit them to more repeat interventions. And I think we need to emphasize that point.
Mehdi, the other issue, though, in terms of the drop of DCB utilization, at least in the United States, is not necessarily linked to this, but also linked to the reimbursement issue. And I think those two things have to be separated, because let's face it, in the US and the way we practice medicine, a lot of it is driven by reimbursement, and it's not necessarily driven by clinical data. Doctors out there are making the decisions based upon whether they get paid or not based upon this.
Mehdi, one more point, that the lowering of utilization or DCB may not be at a provider level per se. I encourage you to also think in terms of acquisition by healthcare systems. And that, there are some data I don't want to name on the air, but there are evidence to suggest that some healthcare systems have reduced acquisition of this technology, which can cause a real drop in the sale of these devices, not necessarily at a provider level utilization per provider at each institution. So I think there are various factors there, and Carlos raises a great point.
Anybody else? I give it one. Vic, maybe you can get the last comment here. Any final thoughts on this, and then I make some closing remarks, if that's okay.
Very briefly, I think you can use DCB safely now, but I think it is incumbent on all of us to be cautious, keep up to date with our results, and notify the patients.
Well, I am really, thank you. I'm grateful to the panel. I know Ramon is calling from far away, and I don't even know what time it is over there. I know he said it earlier. Thank you so much, Eric, Vic, Subhash, everyone. And really want to have this discussion ongoing, hopefully at CVI when we're all together. But more importantly, I appreciate all the attendees for sharing their time with us at this time of the evening. Thank you so much, and we look forward to interacting with you in the future.
And yes, this program is recorded. This is a response to a chat question, and it will be posted on the CVI website. So please visit cvinnovations.org, and look forward to seeing you all in Denver, July 17th to 20th, 2019. Make your reservations. Thank you all for joining.
Thanks so much. Thank you.
Thank you, guys.
Thank you.
Bye-bye.